Dr. Moss is a member of the Public Policy Committee of the New York Statewide Senior Action Council and a member of the advisory board of PNHP New York Metro Chapter. He has PhD in philosophy with an emphasis on social and political theory. His research, writing, and presentations on long-term care have brought greater attention to this very important area of healthcare policy for both the state and the national single-payer advocacy groups. And I'll add to that he's a pleasure to work with. So, Henry, you're on.
Okay, I've been doing this long-term care stuff for a number of years now. And I'm pleased to see that it's getting some traction as a way of supporting and advocating for the New York Health Act. But but it's not far enough. It hasn't gone far enough. We haven't done enough with long-term care. There's still this prevailing belief that long-term care is the way we organize old people. And, it's a natural thing. Oh, that's long-term care. There's long-term care, there's cancer care. Long-term care is a different animal than the other types of benefits that occur through the New York Health Act. Its range of potential supporters is huge. Not just old people, but people who soon might be old, the people who take care of old people, the people who know other people who take care of old people. It's a universal concern, and it's not just for old people. So I hope this talk today tonight will kind of reinforce that and have a greater emphasis on long-term care in terms of organizing to eventually get the New York Health Act past the finish line. The New York Health Act has been considered in the legislature for several decades now, sponsored by our good friend Richard Gottfried, who's here. But it wasn't until 2019 that long-term care was included as a benefit. Up until that time, long-term care was something that was going to be considered only after the bill had been enacted. And also in 2019, the Bernie Sanders bill, the Senate bill for Medicare for All, also decided to include long-term care. It didn't do much for nursing home care, but it certainly included home care. And the Jayapal bill, at the same time, greatly expanded their understanding of long-term care. It had been a couple of lines in the prior bills, and it was barely mentioned. But in the Jayapal bill, they go into it much more extensively. They talk about activities of daily living. They talk about what long-term care is. So basically, 2019 was a turning point, and I think it's a major turning point, a major step forward for the single-payer movement, and should significantly increase support across the board. So, what is long-term care? Not everybody fully understands it. It's personal care, typically delivered by an aide in an institution or in a home setting to assist residents with carrying out basic activities of daily living, so-called ADLs. Basic ADLs would include things like toileting, dressing, feeding, movement in and out of bed or a wheelchair, but it also includes instrumental activities of daily living, so-called IADLs, things like laundry and housekeeping, shopping, and cooking. The definition also includes a variety of home modifications and assistive devices that support daily living activities. Fully covering long-term care for all New Yorkers, especially home care, will be a game changer for New York families. Medicare doesn't cover long-term care. A lot of people still don't understand that. It only covers 2 or 3 months of care in a post-acute setting. After you've been in a hospital, they send you to a rehab facility, which is often a nursing home, but that's not long-term care. Public and private health insurance plans don't cover long-term care. Private long-term care insurance is not only too expensive, it's also incredibly unreliable in terms of what the expectations would be when you actually need it. Only Medicaid covers long-term care, and pretty comprehensively, actually. But the services are only for people who are very, very poor, very low income, and with few assets. So what will this new benefit mean for the rest of New York? Well, the new benefit will mean that younger adults with disabilities will no longer have to forego higher education or turn down jobs in order to stay poor enough to qualify for a Medicare home care aid. It will also mean that older adults who don't qualify for Medicaid, but who cannot afford an institution or an aid, will no longer have to impoverish themselves to qualify or sit home alone in unsafe conditions, conditions that can lead to things like falls. Falls among adults 65 and older caused over 36,000 deaths in 2020. Also in 2020, emergency departments recorded 3 million visits for older adult falls. Older adult falls generate $50 billion in Medicare, in medical costs annually. My mother, as she was descending into Parkinson's dementia, fell 5 times in 1 year. That meant 5 ambulances, 5 emergency departments, several overnight stays in hospitals, and a hip replacement. I mean, we're talking serious problems if you're leaving people sitting at home alone without an aid and without anybody to support them. And there are a lot of old people in New York State that are continuing to sit at home, even drive, and we have to worry about them. The new benefit will also mean that relatives, mostly women, of course, will no longer have to quit their jobs or reduce their hours, typically during their peak earning years, to take on the financial, physical, and emotional burden of caring for a loved one. A 2011 study found that the average income-related losses sustained by family caregivers who are aged 50 and older, who leave the workforce to care for a parent, the annual loss is about 300, over the caregiver's lifetime. The lifetime loss is about $300,000. I thought that was kind of amazing. It seemed like it was too high. But when they broke it down, they not only saw that there was lost wages, there was lost Social Security benefits, there was lost pension benefits, lost raises, lost promotions, and a ton of out-of-pocket expenses that went along with the caregiving process, even if it could mean driving to a relative's house, twice a week, 45 minutes away. So that was 2011. The figure could certainly be much higher now. A lot of these women who leave the workforce to care for an older adult, not just women, but men also, are trade unionists. So we often tell the unions that won't support the New York Health Act that, hey, your union plan doesn't have long-term care. And they're still thinking, well, long-term care is for old people. But 2 things they need to realize as we talk to them. Number one, if they have to leave the job, they're leaving the union and they're leaving their health care behind. So that's the first thing. And the second thing is, it's not just you and it's not just your parents. It's your friend who's taking care of a parent. It's your cousin who's taking care of a parent. It's someone who's sick and getting sicker. It's someone who just came out of the hospital with cancer, in cancer treatment. You touch dozens of people and you don't realize it, who are somehow involved in long-term care, who know someone who's involved in long care, who'll soon be needing long-term care. So that trade unionist has to stop thinking about, well, what do I need? And has to start thinking about what does his full extended family and friends need. So why did it take so long to include long-term services and supports in the New York Health Act? There are lots of reasons, but the most important was cost, especially given that New York is already spending far more public dollars per capita on long-term care than was being spent by other states. I mean, when I looked at the numbers, I was kind of shocked. I don't know, maybe Dick was part of that reason for that, but New York spends a ton of money on Medicaid and Medicaid long-term care, far more than any other state. But that's a cost issue. And we all know that the need is going to be rising as we baby boomers start becoming octogenarians in large numbers in 2030. And the prevalence of chronic illnesses and care needing diseases is going to be growing. It's estimated by 2050, the prevalence of Alzheimer's dementia nationally, for example, is probably the most care intensive of conditions, is expected to be triple what it was in 2010. And that's just Alzheimer's. So not only are we entering our 80s, but we're going to be entering our 80s suffering from chronic illness. Sort of funny, you survive a heart attack when you're 50 in order to get Alzheimer's when you're 85. And that's sort of the situation that we're in with respect to long-term care. Now, former Governor Cuomo was certainly concerned with rising costs. In 2011, he invited private insurers to run managed care, Medicaid managed long-term care. He introduced Medicaid managed long-term care in 2011 to be run by private insurers. His promise was that private insurers would save money without reducing quality. So that's been now a nice experiment that we've had for 12 or 13 years. And the end result has been that A, didn't do much in the way of savings, and B, didn't do much in the way of quality of care either. But what it did do was siphon hundreds of millions of dollars, maybe even billions, into the pockets of these private insurers. In 2020, Cuomo took a different tack. He decided the most efficient way to reduce Medicaid spending or to control Medicaid spending was to simply cut the long-term care benefit in New York State. So he raised the medical and financial eligibility standards significantly, and he tightened the evaluation system used to determine whether or not someone needs long-term care. That was done through his MRT, his medical redesign team came up with it, and it was introduced in the 2020 budget, and that became law. Now, in terms of medical eligibility, you would need to have a nursing home level of care, which the Cuomo bill called 3 activities of daily living or more, in order to be able to qualify for Medicaid home care. Up until then, you didn't have any restrictions. You just needed to have any need. You needed something, you needed to have help with showering, you needed to have help with laundry, you got it, assuming you have enough aides around. In the financial front, Medicaid long-term care didn't have a look-back period in terms of your assets. Nursing homes, they look back 5 years to make sure you haven't given away your assets in order to qualify for Medicaid. So they look back 5 years to see what your finances were over the previous 5 years. Home care didn't have the 5-year look back. Why? Because people recognized that home care was actually cheaper than nursing home care. So that back when this was introduced, the idea was, let's put more people into home care. People want home care. They don't want nursing homes. So there was no look back period. So in 2020, Cuomo introduced a 2.5-year look back period. He also tightened eligibility standards by coming up with a centralized assessment system to take the decision-making about whether you would qualify away from your private physicians and put it into the hands of a centralized objective evaluation body. So between the medical eligibility standards, the financial eligibility standards, and this new tightened evaluation system, new enrollments into Medicaid would drastically reduce new enrollments into Medicaid long-term care, drastically reduce it. Wouldn't affect people who are currently receiving it, but from 2020 on, October 2020, it would reduce the ability of a new applicant to qualify for Medicaid long-term care. Now, there was a delay in implementing this due to the pandemic, so it hasn't yet been implemented. However, the expectation is that it'll be implemented this year. So it might be another reason why we really have to push hard on the New York Health Act, because starting probably in April, maybe in July, people who are going to sign up for Medicaid on the basis of how it had been done in New York State for years are going to be turned down. I'm sorry, not Medicaid long-term care are going to be turned down. So that's another reason for the New York Health Act to get implemented. So what did Cuomo do? Despite an aging population and projected increases in chronic disabling conditions, he pushed for cuts and austerity. We're pleased to see that Senator Rivera and Assemblywoman Paulin have introduced legislation aimed at reversing these 2020 cuts. Senate Bill 328, Assembly Bill 6346. And it's what the bills do is very simple. We reverse these cuts. They're no longer to be in law. So we should be supporting that. Also, recently, Rivera and Paulin introduced an interesting bill called Senate Bill 7800, Assembly Bill 8470, calling for the elimination of private insurers from Medicaid managed care. That was a shocker. I didn't expect that. It happened, I don't know, a couple of months ago or so on. But what that's done is it's triggered a huge backlash from insurance companies, health plans. Even my local newspaper up in Riverdale had a large op-ed from an insurance company that said, don't support this bill. So it must be doing something right. So I strongly suggest that NYPAN get behind Senate 328, Senate 7800, and the associated Assembly bill, which would, one, reverse those Medicaid long-term care cuts, and two, eliminate private insurers from managed care, so as to save potentially hundreds of millions, probably billions. The bill 7800 calls for reinvesting that into higher pay for home care workers and support for the home and community-based services. So, but still leaves the question of added cost. In 2017, the bill sponsors contracted with the respected RAND Corporation for an economic analysis of the New York Health Act and asked RAND to include a cost projection for adding long-term care. The analysis concluded that the added cost would be relatively modest. An important component of that analysis was the prospect of replacing family care with a paid care aid, and maybe that was going to cost too much. RAND estimated that only about half of unpaid care would convert to paid care, and other studies have confirmed that estimate. In 1999, Scotland introduced a no-cost long-term care benefit, set aside a pool of money in anticipation of a gigantic rush to take advantage of that. It turned out Scotland was quite surprised that the pool was initially barely used. Later on, it began to be used more, but what they discovered was that family members do want to help take care of their families, their older relatives, their disabled relatives. They do want to help out, but they need support. They need help with the most difficult cases, and they need the opportunity to be able to continue a career or a job or to pursue education. So the idea that there was going to be this massive rush turned out to be not true. There was eventually an uptick, significant uptick in Scotland's use of this benefit, but it wasn't a catastrophe. How would we pay for long-term care? Well, we pay for it the way we know we pay for everything through the New York Health Act. We save a ton of money on administrative expense, reduced administrative expense. We save a ton of money on reduced administrative expense, both in the insurance companies and in the providers. We save money on the pharmaceuticals. We keep control over costs. We can keep our hospital costs down. We can bring our hospital costs down. So those same things that we use to promote the bill would allow for the introduction of a long-term care benefit. We did a study about what the tax increase would be based upon a model. So we picked a random model of the New York Health tax and figured out that someone earning $50,000 annually would only see an increase of about $120 in taxes as a result of adding long-term care. And someone earning $100,000 would see about a $440 increase in their taxes. Today, that would be a little bit higher. That was done about 4 or 5 years ago. But hey, $120, $440, that's a pretty good deal for long-term care insurance, because that's what the New York Health Act is, long-term care insurance. Okay, so to wrap up, there'll still be a lot of issues to be addressed, including the shortages of available aides, especially in rural counties, the shortages of staff in institutions, shortages of dentists. Increasing provider reimbursement and wages may not be enough to solve these shortages, and there may be need for appropriations from general funds. Just as Cuomo a few years back offered emergency funds to help reduce waiting lists in central New York, the governor and the legislature may have to come up with additional funds to make long-term care a reality. We obviously can't do it if we don't have the aides to take care of folks. Also, while Medicaid long-term care in New York is quite comprehensive, there's still a number of constraints that would need to be addressed. Agency aides are frequently abused. It's difficult to control how much an agency, particularly a profit-making agency, and about half of them are profit-making, is actually paying their workers, because it's a private issue. So that may have to be addressed. There are limitations in what they can do. There are limitations in their advancement potential. So all these things have to be considered, perhaps out of the New York Health Trust Fund, perhaps out of general revenues. And frankly, one of the things I'm very concerned with in institutions is Medicaid does not allow for private rooms, only for semi-private rooms. You have to have a roommate in an institution. I think that's terrible. I think that's a violation of the Olmstead Act, frankly, to not have privacy. If a family member wants to pay extra to have privacy for their parent, it won't be accepted by Medicaid. That's considered income. So that's one of the concerns I have about long-term care in New York, is we should have private rooms. That's a costly process, but that's down the road. So ultimately, the way this thing gets financed is you'll have the New York Trust Fund. They'll have federal monies going into the New York Trust Fund, the New York Health tax dollars going into the New York Trust Fund, similar to the Medicare Trust Fund. And this will be used to finance the program, the full New York Health program, as well as the long-term care piece. The governor would also submit every year to the legislature an annual revenue plan to cover all program costs, including presumably ending the shortages, but not sure how that would work. So adding a long-term care benefit will bring on a number of new constituencies into support for the New York Health Act, and will increase its chance of passage. The message I want to leave you with is use it. It's a great lead into our organizing. Even the folks upstate, even Republicans, are taking care of their parents, and we can use this as a major source of support for the New York Health Act. Thanks.
Well, thank you, Henry. Really appreciate your coming in. I see Dick gave you a thumbs up, even high praise. So if people have questions, just stick them in the chat, please, and we'll try and amalgamate them and feed them over to Henry. Henry, you up to doing questions now, or?
Sure.
Okay, good. So the first one is a tricky one. Donald wants to know about how people with current long-term care insurance will be treated. How can that be converted or rolled in, or what happens to that money, basically?
Yeah, Henry, you were kind enough to answer me by email, but I thought the rest of the community would benefit from seeing it.
My best understanding is that if you have long-term care insurance, you should drop it. I don't think anyone's going to reimburse you for it. However, as I told Donald, when you go into a nursing home, Medicaid will not pay for room and board. And that's because they take your Social Security check and they use that toward room and board, leaving you with $50 spending money each month. So one of the things you can use the long-term care insurance for, if you want to keep it, is to help pay for room and board in a nursing home, should you need a nursing home. Frankly, I wouldn't do that. It's an expensive proposition. You may not need it. And of course, if you buy it at age 40 or 50, who knows what the price is going to be when you're 80, or if the company's even going to be there, and if the policy is going to be, hasn't been changed. So it's a tough, it's really for people who've got a lot of money to spend on something like long-term care insurance, but that's the best I can do on that one.
So we don't have a good argument about it. That's because I've come across it also in doing presentations to the public. People that have it tend to not want to have anything to do with the Health Act.
Well, they can keep paying premiums on the private long-term care insurance. That's their prerogative, I suppose.
Right, but we don't have a good argument then as to why they should think about the Health Act as an alternative.
It reminds me of some of the trade unions who want us to reimburse them for the wages they lost when they were negotiating their wonderful health plans. I don't have an answer for that one either.
Okay, anybody who wants to, by the way, who didn't get an email from us about this event that wants to get on our mailing list, please just put your email in the chat and we'll pick it up out of there. So we can give it follow-up, including, Denise is here, including the bill numbers and a link to the recording and so forth. So any other questions here? It was very thorough. Maybe we're not going to get too many questions. It's very heartening to hear that we're moving in that direction. Now, Dick.
Yeah, well, not a question. I just wanted to mention a few things quickly. One is that, and I've said this to Henry, but I want to say it to everybody. Back several years ago, when people were urging us to include long-term care in the bill, I and others were really very scared about doing that because it seemed like a bottomless pit. At least with regular insurance, health insurance, the vast majority of New Yorkers have health insurance. And so, while it has enormous problems, the number of completely uninsured was pretty small. With long-term care, the number of completely uninsured is darn near everybody. But Henry did a lot of very detailed research and documented what the costs would likely be. And Henry's research, as far as I'm concerned, played an enormous role in moving me and others to deciding enough about waiting for future studies. We're just going to put long-term care in the bill. One thing about the term long-term care, I have found over the years, including years ago in conversations with my own mother at the time, was that when you say long-term care, people assume you mean nursing home care. And I remember talking to my mother about buying long-term care insurance for her. And she said, no, don't do that. I don't want to go into a nursing home. As if not having long-term care coverage, A, would keep her out of a nursing home, and B, as if long-term care coverage only covered nursing homes. Anyhow, and so every time I use the term long-term care, spoken or in writing, about the New York Health Act, I say long-term care, parenthesis, home care and nursing home care, close parenthesis. And I hope that helps. People who have long-term care insurance, I'm one of the tiny minority of New Yorkers who have it. I think partly because years ago I figured that if I was the health committee chair, I had sort of a civic obligation have long-term care insurance. That was what a good citizen did or something. I don't know. Anyway, so my wife and I have this coverage. Um, it costs us, I think each of us over $6,000 a year. Um, and it would cost even more, except we had bought it when we were we were a lot younger than we are now. And I think part of the answer to people who say, gee, I have long-term care insurance is, well, you're lucky that if you had needed it in the last several years, it would have been there for you. In the future, you will get dramatically better long-term care coverage from the New York Health Act than your policy would give you. And you're no longer going to be paying 6 or 7 or whatever thousands of dollars a year that you're now paying in premiums for that coverage. It'll stay in your bank. Think of what you could do with that.
Right. And just a quick side note here, in case anybody doesn't know, Dick Gottfried is the original sponsor, the original Rays of Pizza. He is it. He brought it out in 1992 and been fighting for it ever since. And we honor him immensely.
Thank you.
Thank you. Couple questions in the chat. One person asked, I'm not sure you got an answer for this though, Henry, about if they have long-term care, you seem to be implying they should drop it. I'm not sure that's what you meant, but that's what the question is.
No, I'm saying unless you're willing to pay the premiums, if it's implementing the New York Health Act makes long-term care insurance superfluous. So, but you may want to use the premiums to pay your room and board in a fancy nursing home. There are a lot of fancy nursing homes up here in Riverdale where you're still going to have to pay a lot of money if you want to be there, even if the New York Health Act takes effect. So there's some potential use for it. It was a personal comment that I wouldn't keep it if I had the insurance.
Right.
Didn't mean to discourage anyone.
Okay. Julie, I guess you in 1 second. Mary and Joel both asked somewhat similar questions about provisions for home health aides, and does long-term care include assisted living? Is there a provision to, I guess the problem seems to be that people think that the agencies are getting too much of the cut currently. Is there any kind of provision to encourage independent?
That's a good question. I think right now 50% or more of the home care agencies, are for profit, and the New York Health Act does not preclude a provider from being for profit. It just won't incorporate the profit into the consideration for what kind of reimbursement rates they would receive. So I think the bill itself will begin to open the door for independent operators to come in, because profit is ultimately at some point going to interfere with, especially in things like home care agencies, where labor is 90% of your what you're doing. So my guess is that would help, but as far as I can see, if there are laws that say, and there are now laws that say you have to pay the minimum wage to a new home care worker at $17 an hour, and if they're not getting $17 an hour, then ultimately I think you have to enforce that through whatever mechanism you would enforce any minimum wage law. So it's an interesting question. How do you force the agencies to actually pay the aides properly and not abuse them by screwing around with their schedules or putting them into part-time status or cutting back their benefits? These are all really important questions. But when you're dealing with for-profit providers, you have ultimately, I think you need an enforcement mechanism. Of course, it would help to pay for Medicaid to pay a little bit better, because some of these providers are legitimately in financial trouble because they often don't pay the workers, not because they don't want to pay the workers, because they just, they're not making any money at all because Medicaid rates are so low. But, if they should get out of business. Let an independent operator come in that doesn't need to make profit. Tough question. Good one.
Oh, we've got another one lined up, but Julie, you're first before the tough question.
Thank you. Mine's actually a comment more than a question, and it speaks to our organizing. I think it is so prevalent that people think Medicare covers long-term care. It's almost not thought about. I'm embarrassed to say that as a young physician working in a hospital, I thought when our patients were discharged for home care that it was long-term care, but it was short-term care, and that distinction is just not very well known. So I think in our organizing, that would be something important to talk about. I think the vast majority of people have no idea. They just think, oh, I'll get old and, Medicare will take care of this. So it's a talking point for everybody, including legislators and their staff. Thank you.
Okay, if there's no comment on that, Janet is asking a two-part question. Is the Health Act a managed care plan? And also, is it a Medicare Advantage plan, which we get a lot of people asking about?
Okay, I'll take a stab at that, and Dick may want to come back as well. In the preamble to the, Judy Fletcher brought this up to me yesterday. In the preamble to the bill, it says that the New York Health Act will try to move away from pure fee-for-service towards global budgets and capitation and managed care, integrated care, so on and so forth. And then it's mentioned elsewhere in the bill. That's created a lot of misunderstanding that people have about what the New York Health Act is. It's going to start out fee-for-service. Any movement toward towards managed care would have to be carefully constructed to the advantage of the patient and towards true quality assessment, not what passes for quality assessment in today's managed care environment, which is pretty much run by insurance companies, if not by private insurance companies, by independent nonprofit companies, which act like for-profit companies because they're out to make money as well. So I think we have to be careful when we use the term managed care. We're not against managing care. We're not against care coordination. We're not against value-based care. There is a care coordination function written in the bill that's fairly comprehensive. So the idea would be, though, by eliminating the profit motive and by eliminating the competition, we would be able to carefully construct a managed care and integrated care environment after starting fee-for-service. Does that capture it, Dick? I mean,
yeah, well, a couple of things. One is that while the bill does talk in several places about promoting care coordination, it defines care coordination as essentially a variety of ways to help make sure people get to the care that their primary care provider or others have recommended for them. It is explicitly stated more than once in the bill that care coordination is not gatekeeping or prior authorization or anything of the kind. And one of the essences of managed care, as it's practiced today, is restricted provider networks, and the managed care plan deciding what people get paid, and that is quite explicitly prohibited again in several places in the New York Health Act. No limit, no restricted provider networks, no deductibles, no copays, and the program, not any third-party payer, determines what providers are paid. There are a couple of provisions in the bill dealing with some very specific situations. For example, if the federal government does not cooperate with folding Medicare into the New York Health Trust Fund, which would be sensible for the federal government, but you can't count on the federal government being sensible. One of the options that New York Health could use would be a managed care entity in Medicare, like, using, what they call Medicare Advantage, but with a couple of massive exceptions. It prohibits any restricted provider network. It guarantees every benefit that anyone is entitled to under either general Medicare or the New York Health Act. It prohibits deductibles, et cetera, et cetera. So it would create what would, on the outside, maybe look like a Medicare Advantage plan, if that's what we have to do to draw down federal money. But it is explicitly stated in the bill that that plan would have to operate on the principles of the New York Health Act: no restricted provider network, no copays, no deductibles, et cetera, et cetera, et cetera. Similarly, there are some pieces in the Medicaid program that, by agreement with the federal government, part of the way we got them to pay for it was by saying we would deliver it through Medicaid managed care. If we can't back out of those requirements, again, Medicaid may want to set up what would really be sham managed care plans, but again, they would be explicitly prohibited from having any restricted provider network, any prior authorization, any deductibles or copays, et cetera, et cetera, et cetera. So your doctor and your other healthcare providers and you would never know that you're in anything that on paper is has a name like managed care. It would simply be a gimmick for drawing down extra federal money.
I would just point out that the Medicare Part C, the Medicare Advantage part of the federal legislation, explicitly states that you can have a public provider of a Medicare Advantage plan. It's not, everybody thinks it's only for private insurers. You can have a public provider. And that, what Dick was saying is we would take advantage of that on a technical level in order to assure that the Medicare funds that are entitled to be given to the eligible New Yorkers would in fact make it into the New York Health Trust Fund. So it's like he said, it would be invisible to the provider and it would be invisible to the patient. They would think they were in the New York Health Act. It would simply be a method for overcoming any resistance to providing a waiver that many people feel should be easy to give by the federal government, but you never know who's going to be running Washington.
Okay.
Exactly.
More on that, Dick?
No.
No?
No.
Okay, great. That's helped me a lot. Evelyn, you had your hand up?
Hello,
Hi.
I'd like to make a couple of comments here. I think it was about 1987 or so that NYSUD first offered long-term care insurance to its members. I signed up then and covered myself and my husband as a member of NYSUD via the PSC. My husband became quite ill about 7 years ago. One of the things that people don't understand about long-term care insurance, in my view, is that it is very minimal. I received, after completing many, many forms, $125 a day for care of my husband, who needed 24/7 care. So the long-term care insurance that is now still available, but limited to NYSUD members who signed up then, it is no longer offered, did not really help me. And we spent most of our savings providing care for him. That's the first point I want to make. The second point I want to make is that unions do not understand or will not understand the importance of long-term care insurance for its members. Professor Moss, in his initial statements, described vividly the growing segment of older people in our society. Long-term care is not an option, it is a necessity. And our efforts seem to me to require that we understand that. The third point I want to make, and finally, is that if you look at the people who are here today, and my screen says there are 48 when there should be 4,800, you will notice very few people of color. We do not, when I say we, people of color, do not live as long as white people to begin with in our society because we are denied access to quality care our whole lives. But those of us who still remain, and I am 90 years old, need to understand and to recruit an army of brown and Black people, particularly as we see our representatives in New York City, in Albany, and in Washington, D.C., increasingly being of color. Ladies and gentlemen, long-term care is a necessity, and we should be motivated in every way to see to it that it is embedded in our way of living. That's all I want to say. Thank you.
That's great. Thank you, Evelyn. Stuart, you're up next.
Yeah. I come from 3 generations of doctors. And when I was a year old, my mother was almost totally paralyzed by polio, and I grew up taking care of her. I was long-term care for my mother until I left for college. And I was also a witness to what a person can do who is, quotes, disabled. And I think that so often we think of disability as some sort of something that's communicable and to be hidden. But the reality is, among other things, that it was a man in a wheelchair who led us, the country, out of the Depression and to victory in World War II. And that when we don't realize the resources we ignore, when we sideline people, when we don't take care of them, we lose enormous value and we become inhumane. And I think that just like childcare, this is a matter of humanity. That's really it.
Yes.
Thank you. Mary, did you want to make a comment about one of Evelyn's points?
Yeah, well, it's a comment and a question. Evelyn made the point that her reimbursement was very low considering the cost that they actually had. But I'm one of those people that does pay for long-term care insurance, and there's options as to how much you want to pay for how much coverage you get. I mean, it's not just a fixed amount. But the question is, then how does long-term care, the New York Health Act, reimburse?
The New York Health Act reimburses the provider. So the provider signs up to be a provider within the New York Health Act. And however Medicaid would pay for that provider on a per hour basis or in some sort of a contract basis or whatever, the New York Health Act would pretty much do something similar with respect to the reimbursement of a provider. So if they provided 5 hours of care a day for an older adult, if whatever Medicaid reimbursed for that is what the New York Health Act would reimburse, but there'd also be negotiations, hopefully, to increase that reimbursement because Medicaid doesn't pay well enough. And I think one of the goals of the New York Health Act is to bring Medicaid rates up, bring Medicare rates up, so that the providers have the resources they need to pay their workers, doctors, as well as to make sure they can get additional supply where needed. So it would be reimbursed the same way the Medicare and Medicaid reimburses, and hopefully at a higher rate.
So not a fixed amount like it is with regular long-term care insurance.
Well, Medicare has a fixed amounts that Medicare comes up with a schedule, and anyone who wants to get reimbursed through Medicare has to take whatever that schedule is. The New York Health Act will negotiate a similar schedule of reimbursement for various providers, doctors, nurse practitioners, psychologists, whoever, and they'll do that same. They'll negotiate the same with the providers of long-term care, which are basically the agencies who then pay their workers.
The bill, by the way, has language which says that we recognize that the legislature recognizes that Medicaid and Medicare currently do not pay enough to cover the cost of providing care. And, you know, the legislative intent section of the bill says this violates the reimbursement standards spelled out in the New York Health Act, and that the New York Health Act would have to raise payment rates for care that would otherwise be covered by Medicare or Medicaid to meet New York Health Act standards. And those standards are spelled out in the bill as having to be related to the reasonable cost of providing the care and sufficient to assure an adequate supply of the care, a standard that today doesn't really apply to anybody's coverage. And so the bill basically guarantees that home care workers are going to be required to be paid a lot better than they are today.